Our next speaker is the leader of our pulmonary critical care JAB group, Dr. Raed Hamid. He's a consultant pulmonary and critical care and sleep medicine in Aurora Sinai Medical Center for Wisconsin. He will talk to us about acid-base balance, a quick review of acid-base balance. And after his lecture, he's going to give us the day one closing day remarks. تفضل دكتور رائد.
مساء الخير جميعا وشكرا كثير لحضور الجميع واسفين انه اخرناكم. نتمنى ان تكون اخر محاضره ما تنيمكم. صراحه الاسيد بيس disorder is really something that very important in every aspect of medicine. طبعا على اي مستويات، على مستوى النيرسز، على مستوى الريسبيراتوري ثيرابيست، على مستوى جميع التخصصات. It's a basic knowledge of any physician to understand البيسك acid base disorder. وراح نبدا نحاول نبسطها ان شاء الله قدر المستطاع. مشكله الاسيد بيس disorder it's a lot of physiology و it's a lot of calculation. بس يعني at the end انا راح احكي لكم السلايدات اللي انتم you have to keep it in your pocket. There is nothing wrong to keep it in your pocket or in your phone, so you can go over it anytime you want. Each day our body actually generates significant amount of acid. There are three types of acids in the system or in your body, and they are divided into three types. أول شيء بيسموه الفولاتايل acid، هو الحامض المتطاير. This comes usually from carbon dioxide. ثاني أكسيد الكربون ينتج بكميات كبيرة في جسم الإنسان، وحسب ما بتعرفوا إنه الكربون دايوكسيد بيرتبط بالماء عن طريق الهيدروجين انهيدريز، وهذا بيعطيك الكربونيك acid. طبعا الكربونيك acid at some point will dissociate، بيعطيك الهيدروجين والبايكربونيت. فهذا اكبر مصدر لتكوين الاسيد في الجسم. النوع الثاني من الحامض هو الاورجانيك اسيد، الاحماض العضويه. واكثر حامض عضوي بنشوفه بالجسم هو السيتريك اسيد واللاكتيك اسيد اللي بيجي عاده من الميتابوليزم. The body is smart enough، النورمال بادي بيروح وبيعمل ميتابوليزم لللاكتيك اسيد، بيحاول يكون منه مره ثانيه الجلوكوز، واللي بيصير له ميتابوليزم للووتر والسي او 2. ثالث انواع الاسيد هو اللي بسموه النون فولاتايل اسيد، الحامض الغير متطاير. كميته قليله، عاده تنتج عن نتيجه الميتابوليزم للسلفر containing امينو اسيدز in the body. هلا عمليه التوازن الحامضي في الجسم، الاسيد بيس بالانس، عاده is maintained by three processes. Number one, the lungs normally will excrete CO2. فانت اذا كان عندك excess amount of acid, the lungs will help to hyperventilate and excrete that extra amount of acid. عاده also as we said الاورجانيك acid الجسم تبعك بيعمل له metabolism for something that can be useful. وثالث شيء عاده الكدنيز if they are working normally that will help in the excretion of non-volatile acid، الحامض غير المتطاير. هلا كيف الكدنيز they help to excrete the extra acid؟ two processes a little bit more physiology but just to make it clear. هلا عاده الهيدروجين ايون الموجود في البري بيرتبط في certain buffers اللي هم معادلات احماض او محاليل buffers. هاي المحاليل هدفها انه تحول الحامض الى تايتريتابل اسيد، واكثر شيء بنشوفه بالتايتريتابل اسيد هو الفوسفيت، بيعطيك الفوسفوريك اسيد وليتر اون نتخلص منه. ثاني شيء اهم شيء موجود في الجسم هو كاكسكريشن باي ذا كيدنيز هو الامونيا. الامونيا عاده ينشا عن عمليه تحطيم الميتابوليزم اوف امينو اسيدز. فعاده الامونيا بيرتبط مع الهيدروجين وبيعطيك امونيوم اللي هو NH4، هذا بيرتبط عاده مع الكلورايد وبيتم التخلص فيه عن طريق الكيدنيز. Let's go to the basic acid base disorder. هلا الكل بيعرف او ان شاء الله نعرف اليوم انه الهيدروجين ايون concentration حوالي 49 equivalent per liter, so it's a very low concentration. This is about 10th to the million of the concentration of sodium. واذا بتتذكروا البيسك كيمستري، اذا بتعرف الهيدروجين ايون concentration واذا عندك nowadays easy scientific calculator you can easily calculate the pH. The pH is the minus logarithm of the hydrogen ion concentration. Also in your body, pH usually that is comparable with life. It goes between 6.8 and 7.7. Above or below that is usually the patient will likely not make it. Just to remind you of that equation, CO2 with water with the help of carbonic anhydrase بيعطيك bicarbonic or carbonic acid. هذا dissociates into hydrogen and bicarbonate. هلا what is the importance of hydrogen ion and pH? Before we go that, هلا زي ما حكوا زملائي, when you send an ABG, usually you measure the hydrogen ion concentration and at the same time you measure the PO2 and PCO2. هلا التريكي بارت هو البايكربونات ليفل. احنا عاده البايكربونات there are two bicarbonate that are reported. واحد من البايكربونات اللي هو موجود في الاي بي جي اللي هو بتشوفه اندر بايكربونات بالاي بي جي لما تبعت الاي بي جي. هذا البايكربونات it's a calculated bicarbonate, it's not measured. الاذر بايكربونات هو الميجرد عاده اللي بتشوفه في الكيمستري بانل لما تبعت نورمال بلاد بيحسبوا لك البايكربونات as a measured blood. هلا just a few words, لما تبعت انت الاي بي جي بتقدر ان انت ساعتها to measure البي سي او 2 وتو measure البي اتش and then you calculate the hydrogen ion concentration. طبعا بيستخدموا شغله اسمها هندرسون هاسلباك equation. انا I'm not going to go into details with that. اللي بيهمني هو السلايد الثاني. This is what we call the modified Henderson-Hasselbalch equation اللي هي الهيدروجين ion concentration equals 24 multiplied by the PaCO2 divided by bicarbonate level. An example إذا عندك أنت pH of 7.4 عندك الهيدروجين ion concentration roughly is 40 وعلى فرض إنه عندك PaCO2 is 40 فأنت you apply the Henderson-Hasselbalch equation تقدر أنت تعرف الكونسنتريشن تبع PaCO2. فهاي المعادلة is very important لأنه every now and then you might be faced with an ABG that does not make sense and you can use it to just to verify if the bicarbonate is normal is actually is correct or not. فهاي المعادلة احنا بنستخدمها او بيستخدموها عادة to calculate the bicarbonate that is usually documented in the ABG. The other more accurate bicarbonate level اللي هو directly measured in the serum and this is the one لما تبعت انت البلد على الكيمستري لاب under the chemistry lab they can either documented as bicarbonate or total CO2. And again, this is not a partial pressure of CO2, this is a total CO2. In general, the difference is not big. In general, usually, if they are measured at the same time, the total CO2 can be like about 3 milliequivalent greater than the calculated bicarbonate. هلا السلايد وقفنا ثواني.
رائد
هو شكله اي اذا مسكت الماوس ببطل السلايد تتحرك. Okay, so how do we estimate hydrogen ion from pH? This is very important concept. Now there are more than one method and actually I mentioned in the slides here two methods. I'm just going to concentrate on the easier method that I always teach it to the residents. هلا this is what we call the linear method and it's a very easy method. احنا قلنا لما يكون ال pH is 7.4 then your hydrogen ion concentration is 40 nanoequivalent per liter. فالlinear method بتقول لك the following: for every 0.1 unit decrease in pH from 7.4 your hydrogen ion will increase by 10. فإذا if your hydrogen ion is if your pH is 7.3 then your hydrogen ion is 50. If it's 7.2 it's 60. Now if you go the other way around toward the alkalosis, for every 0.1 unit increase in your pH your hydrogen ion will decrease by 10. إذا كان عندك ال pH is 7.5 معناته الهيدروجين ion concentration تبعك is 30 and it's 7.6 it's 20. هلا the other method I'm just not going to mention it. You can guys go back to the slide. We'll have the slides available after the lecture hopefully for everybody. So you can go to this method. The initial method, the linear method, it's a method that is easily recognizable and I suggest you guys stick to it. Okay. Now let's just talk about the definition of acid-base disorders. As a basic knowledge, like everybody know there, in normal pH is 7.35 to 7.45. Normal bicarbonate usually is about 21 to 27 milliequivalent per liter. The PaCO2 roughly between 35 to 45 millimeter of mercury. The definitions, when we say acidemia, then we are talking about the blood. Anytime you mention the phrase emia, that means the blood. Acidemia, it means the decreased pH of the blood, typically less than 7.35. When we talk about alkalemia, then we are talking about increase the pH of the blood 7.45 وهي عبارة زي ما قلت الحامضية والقلوية. Then when we are talking about acidosis and alkalosis, we are talking about the pH at the tissue level and not in the blood. Now, there are 4 types of acid-base disorders: metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. And we will touch on each of them. Also, there is a mixed acid disorder because many times in the intensive care unit, you will find more than one acid-base disorder acting together or acting sometimes against each other. Now, let's start with metabolic acidosis. In my opinion, it's the most difficult, the most dangerous, and the most frequent that you see in the intensive care unit. Now, in general, in metabolic acidosis, there is a decreased pH, and at the same time, there is a decreased bicarbonate level. Why do you get metabolic acidosis? Either there is an increased generation of the acid. We see that primarily if the body starts to increase acid production, either from lactic acidosis, ketoacidosis, or sometimes if there is intoxication of certain material. Number 2, the kidneys might be excreting less amount of acid, and we see that primarily in renal failure and in the distal type 1 RTA, or sometimes there is an increased excretion of or loss of bicarbonate, and you see that in GI loss primarily if you have diarrhea or if you have the proximal type 2 RTA. Now, we divide metabolic acidosis into 2 types: anion gap metabolic acidosis and non-anion gap metabolic acidosis. The non-anion gap, we call it hyperchloremic. Now, why do we have an anion gap? And this is a very important subject to discuss, because anion gap acidosis is one of the most dangerous things that you see in the intensive care unit. Now we go back to basics. Your body is electrically neutral. Usually your body supposedly have a normal pH, and supposedly the positives in the body are equal to the negatives. Now we call the positives cations and we call the negatives anions. Each of those cations and anions can be measured and unmeasured. And when we say measured or unmeasured, it means whether we measure them routinely or unroutinely, because nowadays basically we can measure everything. The most important measured cation is sodium, and the most important measured anions are the chloride and bicarbonate. So if you put sodium plus unmeasured cations should equal the chloride plus the bicarbonate plus the unmeasured anions. And if you just remember basic math, you just put the similarities on one side. So basically sodium minus chloride plus bicarbonate equals the unmeasured anions minus the unmeasured cations, and this is exactly the anion gap. Normal anion gap is 4 to 12 as long as you have an albumin of 4.5. And when you have an anion gap, all what it tells you that you have an excess amount of unmeasured anions comparing to unmeasured cations. Now some labs, sometimes they add potassium to the calculation as part of the unmeasured cations. In that case, actually, your upper limit of normal of anion gap will go up to 16. Now, this is just to tell us exactly why we have an anion gap. If we talk about the unmeasured anions and cations, so on the left side of the slide, you can see the unmeasured anions, and on the right side, you can see the unmeasured cations. And this is just a rough calculation, which tells you that the most important reason for the anion gap is the albumin, because albumin contributes most to the unmeasured anions. That's why, as I said, normal anion gap of 12 is considered to be the upper limit of normal as long as you have an albumin of 4.5. If your albumin level is low, then you have definitely to try to adjust it based on the albumin level. If you go to the literature, you're going to find probably few formulas. This is probably the easiest formula that I found. For every gram a drop in albumin level under 4.5, you actually add 2.5 to the anion gap. I mean, what's the clinical importance of this? If somebody comes to you and his anion gap is 14, then you might think, oh, okay, it's a 14, it's mildly elevated. But if his albumin level is 1, then you know that his probably adjusted anion gap is 20 or 22, that this can be very, very relevant and very important. Now, let's talk about metabolic or anion gap metabolic acidosis. Now, these are actually the causes of anion gap metabolic acidosis. So you remember them as ketoacidosis, and you guys probably see a lot of ketoacidosis, either diabetic, starvation, or alcoholic ketoacidosis. Then there is a lactic acidosis, and I'm going to spend some time talking about lactic acidosis. diuremia, and also the intoxication, which are the salicylate, methanol, ethylene glycol هو الانتيفريز, التولوين, propylene glycol, and pyroglutamic acid. Now, the critical care literature sometimes use this nomenclature. I found sometimes the residents actually like to remember stuff by remembering certain flashy names. So this is what we call gold marks: glycols, oxyproline, lactic acid, diabetes or diabetic ketoacidosis, methanol, aspirin, renal failure, and ketoacidosis. The other type of metabolic acidosis, and just to mention something quickly, in anion gap metabolic acidosis, there is clearly no room whatsoever to give bicarbonate. And I'm not going to go into the argument of bicarbonative acidosis. That's a different lecture. Now, the second type of metabolic acidosis is called the hyperchloremic or the non-anion gap metabolic acidosis. And you can see this in renal tubular dysfunction, such as RTA, renal tubular acidosis, in hypoaldosteronism and potassium-sparing diuretics, or if there is an excess loss of bicarbonate, and you see that primarily there is an excess amount of diarrhea, pancreatic fistulas, diverting ureterostomies or carbonic anhydrase inhibitor. There is also, you can see that in hypocapnia. Very important thing is the infusion of chloride. Anytime you give excessive amount of chloride, you have to lose bicarb. By far in the hospital, the most common reason, especially in the ICU for non-anion gap acidosis, is infusion of excessive amount of chloride. And anytime you give excessive amount of chloride, your bicarb is going to go down, and that's, you call it hyperchloremic acidosis. You also see that a little bit sometimes in cases where you have TPN and the recovery phase of DKA. And recovery phase of DKA, typically the acetones in DKA are metabolized back into bicarbonate. Okay, I lost the slides again here. I don't know what's the problem. I cannot advance it.
دكتور على الجهة الشمال من الشاشة، شمال بالنسبة لك الشاشة، وديسيبل الانوتيشن. هاي. في زوم ان زوم اوت وفي إشارة ماوس، اكبس على إشارة الماوس.
زوم ان زوم اوت.
انت شايف هالبار الجراي اللي على الجنب؟
في مليون ألف شغلة على الجنب.
يعطيك العافية دكتور محمود، تكبس كبسة اكزت لو سمحت.
ما بعرف ليش طلع لي الانوتيشن يعني.
تكبس اكزت إذا سمحت.
اكزت من ايش؟
لا بس في كبسة اكزت على الكيبورد، إذا بتكبسها على أساس إنه آخر كوماند ما ياخدهاش، اللي هي تبعت الانوتيشن أو تبعت
خلينا نشوف وين الاكزت عاد على معلش معنا وقت يا شباب، ما تخافوا بس ما تناموا لانه
حضرتك انت عندك ماك؟
لا انا معي لابتوب، ما معي انتل عادي مايكروسوفت.
اوكي، فهي بتكون عاده الاكزت اسمها ESC، بتلاقيها على اليسار.
اسكيب انا كاتب بس اسكيب ما عماله بيطلع ستوب. وشو اعمل هون؟ اوكي اسكيب، كبسنا اسكيب.
طيب مبدئيا اعمل لو سمحت ستوب شيرنج والله.
Okay, we'll stop sharing and we'll share it again. Okay.
Yeah.
Okay, let's see here. Okay, I'm gonna stop share it and I'll share it again.
Okay, sir. For sharing your screen please دكتور، إذا ستوب اللي هو البرزنتيشن مود بالله ورد then share your screen again.
Yep. Okay. Here we go. Thank you. Okay, so we stopped at the non-anion gap acidosis. If you look at the non-anion gap acidosis or the hyperchloremic, you can tell easily they are really either two major reasons here. Either you are unable to excrete the excess amount of hydrogen ion through the kidneys, or basically you are losing excess amount of bicarbonate through your GI tract. How do you differentiate that? There is another thing that we call it urine anion gap. I'm not going to go into details, but the urine anion gap, it's a simple calculation. It's your urine sodium plus urine potassium minus urine chloride. It's a simple calculation that will make you able to differentiate if your non-anion gap acidosis is due to GI loss of bicarbonate or renal loss or GI or renal loss of bicarbonate. So normal urine anion gap is about 0 to 10, and this is usually normal. Now, go back a little bit to physiology. If you are losing extra amount of bicarbonate through the GI tract, such as somebody is having significant diarrhea, typically the urine acidification system in the kidney should be intact. So whenever you are acidic because your bicarbonate is being lost, then the kidneys will start excreting significant amount of hydrogen ion. Now, hydrogen ion in the kidney has to be excreted with ammonia. That بيعطيك شيء بسموه ammonium, and the ammonium is going to be coupled with the chloride. It goes as an ammonium chloride, and that will result in a significant amount of chloride in the urine, so the urine anion gap becomes negative. Those patients who have a distal RTA, they do not have the capacity to excrete the excess amount of hydrogen ion. For that reason, the NH4Cl will be not high, will be low, and that will result in a positive anion gap. So those actually the last three lines, negative urine anion gap, it suggests that you have a GI loss of bicarbonate. If you have a positive urine anion gap, it indicates that you have a renal tubular acidosis. The hyperchloremic metabolic acidosis is something that you can use bicarb for it if you need. Okay. Now, some limitation of the urine anion gap. Again, I'm not going to go into details. You can read that later on the lecture. But in volume depletion, there is usually reabsorption of chloride as part of the reabsorption of sodium. So the urinary chloride might become low. Also, in chronic kidney disease, you do not have you have decreased amount of NH4 excretion. And also sometimes if you have excessive amount of non-chloride anions in the urine, that will make actually the urine anion gap not a valid tool. I'm just going to pass quickly over this. Okay, let's actually go to another thing. It's called metabolic alkalosis. In metabolic alkalosis, the pH is usually high, above normal, and the bicarbonate is usually high. Now we divide metabolic alkalosis into two major types. One type we call it chloride responsive, and the other type, actually, we'll call it chloride resistant. So the chloride responsive, we call it chloride responsive because if we give chloride to the patient in a form of normal saline or whatever, then the alkalosis will be actually treated and will be reversed. And this is usually associated with the chloride in the urine less than 20 milliequivalent per liter, or some people sometimes use the fractional excretion of chloride, and you calculate it the same way you do the fractional excretion of sodium, except that you change the chloride or the sodium to chloride. So the chloride responsive are usually caused from vomiting, NG suctioning, severe dehydration, and the use of thiazide diuretics primarily. Now, in the chloride unresponsive or chloride resistant, the urine chloride is more than 20, and the fractional excretion is more than 1%. You see that primarily in primary and secondary hyperaldo, a primary and secondary Cushing syndrome. If you use steroids in the intensive care unit, sometimes you see that in certain congenital anomalies of chloride absorption, Bartter syndrome, Gitelman syndrome, MAG deficiency, or if you infuse basically bicarbonate, that will give you chloride resistant metabolic alkalosis. Now, how do you treat that? As I said, usually you treat the underlying cause in general and give IV fluid. In a chloride resistant, they do not respond to chloride infusion, and you need to treat the underlying cause. Respiratory acidosis, I mean, this can be a whole 1 hour or 2 hours lecture. We're just going to go over it quickly. The pH is low and the PaCO2 is high. Basically, you are retaining CO2. You can do that at the CNS. If there is any CNS depression that depresses the respiratory center, in neuromuscular disease, Guillain-Barré, myasthenia gravis, ALS, muscular diseases such as myopathies or dystrophies, skeletal disease, primarily if you have a scoliosis, upper airway obstruction, and alveolar hypoventilation. In respiratory alkalosis, The treatment actually go back for respiratory acidosis is try basically to improve your ventilation by increase your tidal volume. Respiratory alkalosis, the pH is high, but the PCO2 is low. And again, these are the causes. Anything that will make you hyperventilate, from anxiety to fever, pregnancy, PE, early salicylate poisoning, because late salicylate poisoning will give you anion gap acidosis, CNS stimulation, and in people with hepatic encephalopathy. Okay? Now, أبو الطراونة كيف إحنا والوقت؟
You have 8 minutes left.
اوكي بدك تعطيني 5 دقائق زياده زي ما اتفقنا.
بعطيك 6.
لاكتيك اسيدوسيس. تسلم. Lactic acidosis, it's a very dangerous thing and makes everybody panic whenever you see the lactic acid level that is very high. Now, lactic acid as a chemistry or biochemistry or organic chemistry, two isomers. There is an L isomer and they are the D isomer. Basically, they are just mirror image of each other. Now, the L-lactate is the one that we measure routinely in the lab. We send it to the lab, you measure the L-lactate. The D-lactate is not measured routinely, and you have to specifically ask for it. We divide lactic acidosis, the L-lactate, into type A and type B, and this is a clinical classification. So type A lactic acidosis, basically, any time that you see it primarily if you have inadequate tissue oxygenation, perfusion, or severe infection. This is the type that you see it primarily in the intensive care unit, and you treat it by treating the underlying cause. Now, the type B lactic acidosis, we see it every now and then, and it's primarily related to medications. It has nothing to do with perfusion, infection, or oxygenation, but usually most of these patients, they might have actually certain inadequate oxygen delivery as a result of certain genetic predisposition and abnormal metabolism in their body. Whenever they are exposed actually to certain amount of medications, they usually have an accumulation of pyruvate and subsequently lactate. So the list is there. I mean, everybody probably know the metformin is a big one, but also we use it with doburamine, epinephrine, etomidate, linezolid, lorazepam, and primarily certain HIV medication. We see that also primarily with leukemia, lymphoma. So be aware of these things. It's not uncommon. We see it a lot primarily in metformin in those patients who have abnormal kidney function at baseline. Now, the D-lactate is something that you have to think about it in order for you to be able to remember it. And as we said, the D-lactate is not measured routinely. You have to specifically ask for it. And the D-lactate, usually most of the patients with D-lactate or D-lactic acidosis, they're going to have an underlying surgical problem or abdominal problem or old surgery that predispose them to bacterial overgrowth. Lactic acid in the D format is usually actually produced by anaerobic bacteria in the gut. It works on the carbohydrate and it produces significant amount of lactic acid, primarily after large carbohydrate meal. المريض عادة بيجي with a neurological symptom, actually non-specific neurological symptoms. The patient will have anion gap acidosis. You go through the whole differential diagnosis, including the lactate will be normal. But in the right clinical setting, with the right surgical history and right CNS, with the CNS problem, you think, okay, this could be a D-lactate, and everything is normal, and there is something that we cannot measure for, so you send the D-lactate. You have to specifically send for it. By the time you get the result, hopefully the patient will be better. It takes some time to get the result back because it's not done routinely in every lab. A quick thing also, another thing that gives you anion gap acidosis is pyroglutamic acidosis. Pyroglutamic acid, primarily we see it in people who take significant amount of paracetamol, acetaminophen, that result in pyroglutamic acid, and that will result in lactic acidosis. Propylene glycol is a solvent عبارة عن مذيب يستخدم في عدد كبير من الدريبس, primarily lorazepam, diazepam, etomidate, phenytoin, ismilol, nitroglycerin. Whenever you use those drips in large concentration in somebody who might have an underlying renal or hepatic dysfunction, then you're going to have increased anion gap. You go through the list, you could not explain it, but this patient is in a large amount of dose drip, and you have an anion gap that could not be explained, then think of propylene glycol. You have to change or switch the sedative agent or the medication into something else. A propofol infusion syndrome, one of my friends talked about this before. There are definitely much more people who read about this disease rather than actually seeing the disease itself. Usually propofol, it's metabolized by an RBC enzyme. For whatever reason, sometimes patients might start using it for source of energy, especially when you use it in high doses with underlying hepatic disease or renal problem. Those patients will have significant amount of lactic acidosis as a result of that. Suddenly, the patient will deteriorate into arrhythmia, heart failure, rhabdo, hyperkalemia, acute kidney injury, bradycardia, hyperlipidemia, shock, lactic acidosis. You have to discontinue propofol and support the patient till they get better. We don't see it a lot. Okay, now this is a slide that you have to keep it in your pocket. If you're gonna remember anything from this lecture, these are actually the 6 steps that you have to remember in order for you to be able to analyze any acid-base disorder. Number 1, start to get the habit by calculating the anion gap first. Because if you have anion gap acidosis, if you have increased anion gap, almost always you will have anion gap metabolic acidosis. I say almost always because there is only one condition that will give you a high anion gap without acidosis, which is if you have severe alkalosis. The severe alkalosis will unmask significant number of negatively charged molecule on the surface of the protein. So that will give you more unmeasured anions and increase anion gap without acidosis. So once you determine anion gap first. Number 2, look at the pH. For the sake of your calculation, normal pH is 7.40. If it's 7.39, then this is an acidosis. And if it's 7.41, then this is an alkalosis. Once you determine acidosis or alkalosis, try to determine if this is a metabolic problem or respiratory problem. And this is by looking at both PCO2 and bicarbonate. If you determine that it is a respiratory problem, then this is acute or chronic. We'll talk about that. Step number 5, anytime that you have metabolic acidosis, normally you should hyperventilate in order to wash out CO2 so you can bring your pH down. So anytime you have metabolic acidosis, you have to determine if the respiratory compensation is adequate, and we'll talk about that. And step number 6 is calculating the delta, and you only do it in one scenario if you have anion gap acidosis, and this is in order to find out if you have another acid-base disorder. Okay? Okay, start again. We have 3-4 more slides left. You have to click that, decline the annotation, and that's what happened. Okay. Okay, same problem here. Why do you keep getting that? Okay, send that again because I declined you. Okay, go ahead, Abdurrahman. Save our life as usual. Okay, great, thank you. Okay, so going back, as I said, in metabolic acidosis, if you have metabolic acidosis, you should hyperventilate to wash out your CO2. So how do you know if you are able to compensate normally or not? This is what we use, what we call Winter's formula. It's another formula that you have to remember if you are really want to be a good physician in the hospital or in the ICU. Now, the Winter's formula, it's a formula that will make you calculate the expected PCO2 for that level of acidosis. So it's basically you multiply your bicarbonate by 1.5 plus 8 plus minus 2, and that will give you a range. So if your expected PCO2 is more than the observed, then you have superimposed respiratory alkalosis. So for instance, if your expected is 30 and observed or actual is 40, then you are doing a very good job below the expected and you have respiratory alkalosis. If your expected is less than your observed, then you have a respiratory acidosis. I have like an example later on. Now remember, in metabolic acidosis, you hyperventilate, but your PCO2 will never go below 10 millimeter of mercury, because then you will become apneic, because your CO2 will go below the apnea level. Okay? Now, the sixth step is the delta-delta. Delta-delta, it tells you you're starting bicarbonate. Before you went into an ion gap acidosis, what was your starting bicarbonate? And there are actually two ways to do it. One of them is called the delta-delta, or one of them is called the starting bicarbonate. So the delta-delta, you calculate actually the difference between an ion gap minus the difference in bicarb. So the ratio between an ion gap divided by the ratio of the bicarb. If you get a ratio of less than 1, it's concurrent non-anion gap acidosis. More than 1.5, it's a concurrent metabolic alkalosis, or we can use what we call the starting bicarbonate. It's your bicarbonate plus the change of anion gap, normal anion gap of 12. If you get a number that is more than upper limit of normal of bicarbonate, it's alkalosis. Less than 21, which is the lower limit of bicarbonate, is acidosis. I have only actually 4 more slides. So, and I'm going to give you, now this is just quickly in respiratory compensation for metabolic alkalosis. In metabolic alkalosis, your CO2 will go up, your body will hypoventilate in order to retain CO2. There are a few formulas to have the expected PCO2 as well. And also your bicarb will change, but the bicarb change takes time. So, quick example here, you have a 55-year-old male, came with fatigue, abdominal pain, weight loss, diarrhea, and he's very thirsty, and he has history of COPD. If you look at the glucose here, it's very high. Sodium is low. The chloride is relatively normal. Bicarb is very low. PCO2 of 30, and the pH is 7.1. This guy probably has an underlying DKA. So apply what we said. Anion gap here is elevated. So the patient has anion gap acidosis. Then you have to apply Winter's formula, which is 1.5 multiplied by 8 plus minus 2. That gives you an expected PCO2 between 18 to 22. The patient actual PCO2 is 30. So that tells you that the patient is doing a poor job, because he's unable to compensate to the expected PCO2 level. So he has a respiratory acidosis. And if you calculate the starting bicarb for this patient, it's the serum bicarb plus the change in anion gap, and that gives you less than 21, so he has a non-anion gap acidosis. Another quick example, 60 years old, female, she has end-stage renal disease, she missed dialysis, and she has nausea and vomiting. This is actually very important. I always trick the residents. Look at this, please. The sodium is normal, potassium is upper limit of normal, chloride is almost normal, CO2 is normal, PCO2 is normal, and the pH is normal. So if you look at this acid base or these labs, you will say, okay, this is a perfectly normal chemistry, there is no problem. Let's say what happened if you start calculating the anion gap. So the anion gap is 20, so the patient has anion gap acidosis. If you apply Winter's formula, you find that the expected PCO2 between 43 to 48, but the patient actual is 40, so the patient really has a respiratory alkalosis. And if you do the starting bicarbonate, you find that the starting bicarbonate for this patient is 33, so the patient has metabolic alkalosis. So this is the best example of a normal-looking pH and normal-looking electrolytes, but the patient has a triple acid-base disorder counteracting each other to cause a picture of that looks normal. So always start by doing the anion gap. Now, the last 2 slides here. Respiratory acidosis and alkalosis. This is acute or chronic? This is the rule. For acute respiratory acidosis, for every 10 millimeter increase in PCO2 above 40, your pH should decrease by 0.08. And for the chronic, for every 10 millimeter increase in PCO2 above 40, the pH should decrease by 0.03. Your bicarbonate will also change and increase, but the bicarbonate change takes about 6 hours. The pH change takes exactly 15 to 20 minutes. So for instance, if you have a PCO2 of 80, if this is acute, then you apply the formula, you expect the PCO2 to be 7.08. If this is a chronic, you multiply, yet you look at the formula down there, and you find that the pH should be 7.28. Honestly, you cannot find a pure chronic respiratory acidosis. Either you have acute, or most of the time you will have acute or chronic, but this is how you can tell. It's very important to know if the pH is acute or chronic, because usually the actual PCO2 sometimes does not matter. What really matters is the pH. You might have somebody with a PCO2 of 90 and a pH of 7.38. You do not have to put them on BiPAP or intubate them. In respiratory alkalosis, the acute change is exactly the same, except that it goes in the opposite direction. For every 10 millimeter decrease in PCO2 below 40, the pH will increase by 0.08. For the chronic, the change is a little bit less, and the change will be in 0.017. So for instance, if somebody's PCO2 is 20, if this is acute, then you expect the pH to be 7.56. If this is a chronic, you expect the pH to be 7.43. I am sorry I have to go very fast, but this is a lecture. Honestly, I always tell the resident that you have to go over it one time over another. You have to keep repeating this. Anytime you see an ABG, try to analyze it. So you can definitely try to master the acid-base disorder. I will stop here and I will take questions.
رائد، الله يعطيك العافية. محاضرة قيمة جدا. الكيسز كانوا كثير مهمين. I would like to tell you إنه لسه في interaction الساعة 10 المساء في الأردن، وبعد 8 محاضرات لسه في interaction عم بيسألوا أسئلة. كان في أسئلة عن specifically عن DKA. When do you give bicarbonate for DKA, since it's one of the most common admissions with very prominent acid-base balance, acid disturbances?
Actually, the DKA, it's always a question that is being asked, and we always struggle to convince people that you do not need to give bicarbonate. Honestly, I am not a common believer in bicarbonate. The quick answer is you don't give bicarbonate for DKA. Now, if you're going to actually go, and this is actually the short answer, no indication whatsoever for bicarb in DKA. Now, some people believe if your pH is less than 7.1, I believe it's probably less than 6.9. When you have a pH of less than 6.9, many of your actually organs will start failing. You're going to start becoming actually hypotensive. You can have increased the risk of arrhythmia. So some people sometimes might use bicarbonate to improve acidity till your actual treatment kicks in. So the idea behind that is not for DKA as much as to improve intracellular acidity. So your treatment of fluids and insulin will kick in. So it just buys you time. I honestly have managed DKA we have DKA almost every day in our ICU. We manage them actually. I have seen people with a pH of 6.9 and we manage them with the fluid alone. Again, if the patient is extremely low, below 6.9, nobody will really argue with you to give bicarb in order to save the patient. But in general, the short answer is no. If it's less than 6.9, some people believe 7.1. I have not given it to anybody less than 6.9, sometimes just to save the acidity, but it's not indicated.
Dr. Raed, if you have a patient who's very sick and they couldn't get ABG, what adjustment would you take, and would you accept a VBG just to look at the acid-base balance?
Excellent question. Now, the VBG actually, theoretically, the pH actually of the venous gas is roughly about only 0.1 difference from the arterial actually pH. So yes, if you cannot do that, and sometimes in the ICU, you get that morbidly obese patient that there is no way you can get when I talk about Wisconsin, I'm sometimes talking about people who are like 500 or 600 pounds, and there is no way you can get an ABG. Sometimes you get a venous pH, and that will give you actually the pH, which is very approximate to the arterial pH. The PCO2 also, it's about only 3 to 5 millimeter difference. And then you're going to be stuck with the PO2 if you need an arterial gas. Now, I always tell the residents, for DKA, you do not need an ABG unless you need to look at the PaO2. You only need initially a pH and a PCO2 if you want to see the severe acidosis. After that, you have only to follow the anion gap, and you do not even to keep checking pH or PCO2 or ketones or whatever. So it's challenging, but I can tell you with experience in the ICU, if you give me a patient, I can probably safely manage him sometime, and I don't discourage people from putting art lines and get ABG. Now that we have actually we can measure end-tidal CO2 safely and we can follow the saturation, you can probably try to manage till we are able to get an ABG.
الله يعطيك العافية دكتور رائد. DKA is صح الناس يعني في كثير أسئلة على DKA since it's a common subject. Sorry to ask. what protocol would you recommend to clearing patients like they are out of DKA? Do you trend beta hydroxybutyrate? You just go by the bicarb, or do you keep repeating ABGs? You just go by the gap?
We only go by the anion gap. We do not follow anything but the anion gap. Now remember, the patient will continue to have high beta hydroxybutyrate and the old days high ketones for days sometimes and days after their DKA is resolved. So there is no indication whatsoever to follow the pH. There is no indication whatsoever to follow either ketones or beta hydroxybutyrate. The only thing that you will follow is the anion gap. How frequent do you do the chemistry panel depending on how severe is the DKA? Sometimes you might need to do it every hour for the first few hours. Sometimes you might actually need to do it every 4 hours or every 6 hours depending on how sick is the patient.
ثانك يو دكتور رائد، الله يعطيك العافيه، محاضره قيمه جدا. انا راح اشكر جميع الحضور، جميع السبيكرز، الله يعطيكم العافيه، وشكرا لزملائنا من الاردن انهم استمروا معنا، وكان في انتراكشن، كان في حضور حوالي 200 لحد 250، 8 محاضرات يوم السبت من 5 ل 10 مساء. الله يعطيكم العافيه. الان راح المايك للدكتور رائد فور ذا كلوزنج ريمارك، والسلام عليكم ورحمه الله.
مرة ثانية شكرا جميعا للحضور، واحنا اسفين جدا انه اخرناكم، بس انا طبعا سعيد جدا انه نتواصل مع ثلة كبيرة من الاطباء في الاردن، والله يعطيكم العافية، وانتم يعني الجنود المجهولين على ارض الوطن. بحب الدرجة الاولى اوجه شكري للحضور اللي رغم الصعوبات ورغم الاكتيفيتيز اللي عندهم وضغط العمل انهم قدروا يتواصلوا ويحضروا هاي المحاضرات، فشكرا جميعا لكم، واسفين اذا وجعنا لكم راسكم. طبعا شكر كبير لاخواننا المحاضرين والاطباء اللي ساعدوا في التواصل وفي اعداد هاي المحاضرات. طبعا زي ما بدا صديقي وزميلي الدكتور بهاء الشباني، نشكر بالدرجة الأولى وزارة الصحة على إعطائنا الفرصة للتواصل مع زملائنا عن بعد. الدكتور نذير عبيدات هو أستاذنا، درسنا في الجامعة الأردنية، أعطانا الضوء الأخضر من عدة أسابيع للانطلاق في هذا المشروع، وإن شاء الله يكون باكورة لأعمال قادمة وتعاون مستمر. طبعا شكر كبير جزيل وشكر جزيل جدا للدكتور محمود زريقات والدكتور ماجد نصير، وكمان الدكتور اسلام مساد العميد السابق للجامعه كليه الطب في الجامعه الاردنيه والمدير مستشفى الجامعه الاردنيه الحالي الذي تواصلنا معه. طبعا الاطباء الثلاثه اللي ذكرناهم كانوا على درجه عاليه من التعاون، وفتحوا لنا افاق ومجالات للتعاون مع اصدقائنا ومع اخواننا ومع زملائنا في الاردن. طبعا الشكر الكبير هنا يذهب الى منظمه اليو اس ايد، طبعا ممثله في زميلتنا وزميله الدراسه دكتوره نغم ابو شقره. تواصلنا معها في البدايه وكانت طبعا على قدر كبير جدا من التعاون، وكذلك قدرنا نتواصل مع الدكتور صبري حمزه وهو المسؤول عن مؤسسه اليو اس ايد، وكان تجاوبه رائع جدا. وطبعا it would not have happened without their help. طبعا الجندي المجهول فعلا في الاعداد لهذا الويبنار هي الدكتوره رجاء خاطر اللي عملت شغلات كثيره، وطبعا اخونا محمود البلبيسي الذي لم يبخل في التقنيه وفي التقنيه. الشيء الكثير اللي انا يعني انبسطت فيه، احنا في بدايه الفكره لما طلعت من عده اسابيع لمساعده اخواننا في الاردن، قدرنا نعمل واتساب جروب وقدرنا نتواصل خلال عده ايام. انا الدكتور الطراوني لم اعرفه الا من 3 اسابيع، الدكتور بهاء طبعا بعرفه من ايام دراسه، كثير من الزملاء المحاضرين اليوم لم اعرفهم سابقا. قدرنا احنا عن طريق التعاون والتواصل والواتساب انه نبني جسور وتواصل بشكل مهم جدا مع اخواننا في الولايات المتحده، ونتمنى ان تكون هذه باكوره وبدايه لعمل وتواصل مع اخواننا وزملائنا في الاردن. المصيبه تعم على الجميع، نحن يعني احنا برضه في وضع برضه شبه طوارئ في الولايات المتحده، لكننا تعلمنا من الجائحه. لا تخجلوا من طلب المساعده. المسج اللي بدي اعطيها للجميع، العمل الجماعي هو السبب الاساسي في نجاح اي مشروع. العمل الجماعي هو الذي يستطيع ان يجعلك تنجح في اي مشروع دون ان ترهق نفسك او ترهق الاخرين. فلا تتردد لطلب المساعده، لا تتردد ان تقول لا اعرف، لان مجرد انك تقول لا اعرف هاي بدايه التعلم. احنا في النهايه جمعتنا للاسف المصائب قبل ان تجمعنا الامور الطيبه، لكن في النهايه انا سعيد جدا ان قدرنا نتواصل مع زملائنا واصدقائنا الموجودين على الارض في الاردن وهون.